गुजरात 1 घंटा हाँ वो सब मीटिंग में है
Yeah, Shraddha, I think we can start now.
Sure, Deepak. Sure. Am I audible? Yeah. Okay. So good morning, everyone. I am Dr. Shraddha Ravane. I'm the manager for global marketing for Merrill Endosurgery Private Limited. And today I welcome you all to this interesting webinar by Merrill Endosurgery Private Limited on optimizing outcomes with surgical technology. Before starting with the session, I would like to play a small video for you all. Thank you so much. Merrill Endosurgery is a one-stop solution for surgeons for providing an extensive portfolio, which comprises of absorbable and non-absorbable surgical sutures, tissue sealants, absorbable hemostats, hernia repair devices, intrauterine devices, energy devices, and mechanical closure devices, most importantly. Merrill Endosurgery products are used in more than 100 plus countries, and we have a rich pipeline to offer in the coming years too. At our webinar today, we have two eminent speakers, Dr. Manish Chand, who will be speaking on optimizing patient outcomes through standardization and technology, and Dr. Marco Adamo, who will be speaking on practical applications of surgical technology in bariatric surgery. I would request you all to place your microphones on mute. For any questions, you could place your questions in the chat box or unmute yourself during the Q&A session. With this note, I would like to introduce our moderator for today. Our moderator for today, Dr. Rajesh Kumar Srivastava. Dr. Rajesh has a fellowship in metabolic and obesity surgery. He is a consultant for bariatric and laparoscopic surgery and also director at Shriji Hospital in Gujarat, India. He is a hernia consultant with HN Reliance Hospital, and he's an EC member for Obesity and Metabolic Surgery Society of India, also Association of Minimal Access Surgery of India. He is the West Zone Director for Abdominal Wall Repair Surgeons Community in India. That was about Dr. Rajesh Kumar Srivastava. We are very happy to have you, sir. So after this, I would hand over to Dr. Rajesh Kumar Srivastava for further introducing our speakers. Over to you, sir. Thank you so much.
Thank you, Shraddha. Thank you, Meryl. It's a great honor to be here. We know technologies in surgery have already been in wide scale in different procedures: artificial intelligence, surgical robots, 3D printing, and new imaging methods are the new tools. Today, technology has evolved into user-friendly, powerful platform that covers a number of aspects of laparoscopy and endoscopic surgeries. Endo-GI staplers are one of the major turning points as far as the outcomes are concerned. So, new methods, new technologies, new ideas of using present knowledge. There is always something new in the list. And to add the new in the list, I will request today's speaker, Dr. Manish Chand, who is MBBS, BSc, FRCS, FAS, CRS, MBA, PhD. He is consultant colorectal surgeon, professor of surgery, and chief medical officer at AIS Channel, the London Clinic. I welcome you, sir. Dr. Manish Chand, please.
Thank you very much for that introduction and the invitation. It's fantastic to be involved in this initial preliminary series from Merrill, company now that I have had some interest with and also following the progress of this wonderful new company as far as we're concerned in the UK and Europe and seeing it grow. I've been fortunate enough to use some of the products and can testify that this is certainly something exciting as far as a new entrant to a very established field already. I'm pleased to be joined by my colleague, Mr. Marco Adamo, who is, of course, an eminent bariatric surgeon. Today, we hope together to be able to talk to you a little bit about surgical technology. So I will set the scene for the various changes that are happening in surgery in 2021. And Marco will go more specifically into the products and the use in primarily bariatric surgery. So I hope you have questions. We will have Q&A sessions after both talks. And I'm very much looking forward to sharing our experiences here in the UK and Europe with you, and also listening to your experiences with these wonderful new products. So I'm going to share my screen now and a little bit of didactic. So I've entitled this Optimizing Patient Outcomes, and I just wanted to make sure you can all see this. Dr. Rajesh, can you see the full screen? I think that's a yes.
Yes, sir. We can see it. We can see it.
Excellent. Okay, so I'm based in University College London. I'm also the Chief Medical Officer for the AIS channel, which you no doubt have heard of as well. So if we look at technology over the last 500 years, you can see that the human species as a whole has very much benefited from automation, mechanization, and industrialization since pretty much the 1700s. And it started with the printing press, which, as you know, was a big invention here in the UK. And gradually, as we see in those 200 or 300 years going in through the Renaissance, and of course, Marco will be able to tell you about many things that happened in Italy during that time. You then see we move into the 20th century, where we move away from large factory style industrialization to more technology. And from the 1950s onwards, we have moved forward at an increased speed. And we see great opportunity here with this, because if you look at our own ability within the OR, we are never working at 100% efficiency. So no surgeon is able to replicate 100% efficiency 100% of the time. And that's perhaps where we can think about how technology can bridge that gap between where we are as men or women, of course, and where the machines and automation and AI comes in. And I think that's what we're going to see. We're going to see technology as a bridge to reach that 100% efficiency all the time in the OR. So we can offer our patients the very best every time we step in to the theatre complex. We've seen the great issues over the last 2 years due to the pandemic, and we've seen big problems here in Europe. Then we saw big problems in the Indian subcontinent, and now we're seeing big problems in the United States. So this has all led to huge pressures, and we were talking about this prior to the webinar today. Huge amount of cancelled surgery. Now, I know for a country the size of India that cancelling 275 people in a week is probably minimal. But in a country the size of the UK, cancelling almost 300 people for cancer surgery is a huge, huge issue. And we know now that there are millions and millions of surgeries that are going to be delayed because of the pandemic, and that's going to take years to clear. So we need to be smart about how we move forward. And in a situation like this, we know from Darwinism, we know from evolution, that it's not the species necessarily that's the biggest and the strongest. It's often the species that's the most adaptable to change that survives. And that's what we're going to see. We all need to think about how to change our practice, change our lives, so that we can not only negotiate this pandemic, but also be prepared for future ones. So how does practice need to change as we emerge into this new normal? We need to see greater efficiency, of course, so that not only do we deal with the current challenges that we have on a daily basis with patients still having COVID and using beds and ITU in the hospital, but also to deal with the backlog and how to get through that efficiently. We need to make our surgery more precise so we get it right first time, so that there aren't mistakes. We don't have to redo surgery. We don't have as many complications. We only have a finite amount of resource, so we need to better allocate that resource. Is it better to buy optimal, excellent products in the first place rather than buy many cheaper products, which may cause a problem? And I think here it's about quality, not quantity. And of course, we need to reduce risk, bring on the use of checklists, look at other industries where they have low rates of error, and therefore reduce our risk, meaning that we can better resource allocate, we can then be more precise and overall increase our efficiency. But technology always has barriers. And this isn't from a Forbes article from a few years ago. And what are the barriers of technology? And the barriers often are that we don't know whether or not a technology actually fulfills a need. What is the unanswered question? And if we bring that technology into the OR, will it slow us down? Will it make us less efficient in the OR? Of course, all technology comes with a price tag. And is this expensive compared to the savings we may get elsewhere? And the last thing is that often technology can be seen to be impersonal. So a simple example is the use of telemedicine. And if we use telemedicine, are we taking away from that human contact that we have always traditionally had during medical consultation? On top of that, technology often takes time to adopt. So looking at this particular curve, going through R&D, eventually moving in through the innovative users at the beginning into general use, this wave can often take a decade or more. And I don't think we have time now with the fast-moving technology to wait a decade before we come up with some exciting new invention and then wait 10 years for it to be in general use. We need to think of being smarter about this. Because if you look at the pace of evolution of technology, only in the early 1990s, when most of us were still at school, and leaving to go to medical school, perhaps. I think for me, 1994 was when I went to medical school, 93, 94. So if we look back then, I remember that there was no Google, there was no real internet, there were no email, but now these technologies and these applications have become so embedded into our life that we can't move around on a daily basis without using these applications. And that means that we need to also think how we can use similar applications and similar technologies in healthcare, because over the last 25 years, we haven't really seen much that's very exciting in surgery. This is an article I wrote with my colleagues, Brendan Moran and Stephen Wexner, a few years ago. And it was really to start thinking about the era of high-tech surgery. So we talk about minimal access surgery as though it's something which is universally adopted. But of course it's not, because in the majority of surgeries that take place, certainly in my field in colorectal cancer around the world, the majority of surgery is open surgery. So we haven't even moved into adoption of laparoscopic surgery, yet we're now thinking about using robots and more miniaturized forms of surgery. So it is about first leveling up that playing field so that we all have equitable access. And there's no point just a few units in the world in ivory towers having wonderful technology if it's not accessible to everybody else. And it's really where everybody else is what matters on a global scale. So what is a robot? Do we truly have robots? Well, the word robot comes from the Czech language, from the word robota. And ultimately it means slave or to be in bondage to one's master. And that's really the best way to describe today's current robotic technology, because they are not autonomous machines. This is an example which I'm sure you're well aware of. This is me doing a case in Apollo Hospital in Chennai on an XI robot, which they have had and they have several of for very many years now. This robot, as you all know, is controlled by the surgeon. So therefore, it fits the definition perfectly. It is not autonomous. It is not capable of making any decisions or movements unless the surgeon controls it from the console. Is this a robot? Well, this robot works to some extent autonomously because it moves. Once you've set it going, it will do its task again and again and again. So we don't even have this rudimentary robotic technology that's been used in car making and industry for several decades now. We don't have this in healthcare because, of course, there would be a huge public outcry at the moment if we didn't present sufficient safety evidence to suggest an autonomous robot or a machine which is going to do repetitive movements is going to do your surgery. This is what we're used to. And this is also known as a telemanipulator, which means that you are controlling this robot in its entirety. It is not truly robotic in the romantic sense of the word. If we need to have robots, and if we're going to have robots, prior to all of that, we need to have a process of standardization. And we've already seen that in standardization practices in the aviation industry, you lead to reduction in error. So that means doing the same thing every time. It means checklists to ensure that there is a reduction in risk. It means setting up your OR the same every time. It means using high quality instruments every single time and not settling for using suboptimal practices. And if you do the same thing again and again and again, you will get less error. There is no debate in that simple statement. So what can we do in standardization of our practice in surgery? Well, we need to avoid bleeding. So if you're going to avoid bleeding, you use good hemostasis. So you may want to use an energy device. You may want to use hemostatic products. But if we avoid bleeding and prevent the complications of bleeding, we are clearly going to have better outcomes. Oh, do we need to use drains? Is using the use of drains, is that something which we should use routinely? If we're going to staple for a stapled anastomosis, and I'm talking specifically about colorectal and circular anastomosis, if we're going to think of that, multiple staple firings for us is not a good idea, because the more you fire staple guns prior to your circular stapling means that you have cross stapling. You have crossing of the staple lines. And we know that if you have more than 2 firings of a endoscopic linear stapler, that you are resulting in the risk of an anastomotic leak in colorectal surgery. Perhaps we need to move on to care bundles, which means that every patient will get a combination of things. For example, in colorectal surgery, again, we will give patients mechanical bowel prep along with oral antibiotics, so that there isn't a worry that, oh, did I forget this? Did I forget that? You have a patient that is allocated a specific combination of products, and that is given to all patients undergoing that particular type of surgery. And then the technical considerations. Technical in terms of how we operate and the steps that we take, but also in the precision that we use, using high quality staplers, for example. So as we move towards precision surgery, I think standardization is the first step on that, and is probably the easiest step for us to do. Audit our practice, standardize our practice, look for error, correct error. Let's see if this video plays it. Hopefully it won't be too jerky. And that means, for example, here in the laparoscopic anterior resection, doing the same steps again and again and again. In these steps, using instruments which are going to cause minimal physiological trauma. So here I'm using a hook diathermy to begin my dissection of the inferior mesenteric artery. It means gentle manipulation of the tissue, no big movements, no big sweeps, not causing trauma or even micro trauma, gentle movements to try and tease out the tissues. And here you can see the retroperitoneal structures gently going down. The use of appropriate energy when required, not the overuse of energy. So understanding where the planes are and being precise. So it's this kind of precision that we want to introduce to our trainees. This is the kind of surgery what we want to propagate when we're promoting good practice. In this video, we can see here now that we are trying to do a low rectal staple. And by doing so, we want to do it in 1 firing if possible. So here we're pretty low down below the peritoneal reflection. And the idea is to get this stapler across in a maximum of 2 firings. So again, gentle movements of the tissue, but also precision in getting to the right spot. And here we're doing it laparoscopically. We do more so robotically these days, but it is all about, there's no point having the best stapler in the world. So if you're given one of Merrill's staplers and you're doing one of these operations, there's no point saying, right, I'm going to rely entirely on the staple gun. You first have to do the precise dissection to be able to let the stapler do what it's designed to do optimally. And then when you're doing a circular anastomosis, talk again, making sure and ensuring precision. So here you have 1 single vertical staple line. You maintain, again, gentle traction and gentle movement only on the rectal stump. I do this myself, so I'm there from the bottom end. And you want to make sure that you are doing the same thing again and again and again. And in this case, we're looking at using a spike that comes out just off center. And then we're able to do our rendezvous technique. Here is the evidence from a paper from a few years ago in surgical endoscopy, showing that the leak rate there is an increased risk of leak if we have more than 2 staple firings. So I think it's important to dissect down, dissect well, take your time, and then no more than 2 firings as you get across the low rectum. Fluorescence. So this is something we're seeing increasingly used in GI surgery. It can be used for a variety of different reasons, and this is an example of what happens. You give an injection of indocyanine green, which is a fluorophore. You do this centrally, and about 30 seconds later, you see this kind of image. Top left is a white light image, middle left is the infrared, and the bottom is the overlay. Where it has become green, or in the middle one, where it has become white in the black and white image, you know that that area is perfused. So you can do it at the time of transection before you've put the linear stapler across. You can then do it intraoperatively at the time of the anastomosis, and you should see the anastomosis turn bright green. And that gives you great confidence that there is blood flowing through that anastomosis at the time of its creation. The meta-analysis that's been done, this is the only significant meta-analysis that's been done. It doesn't include any randomized control trials. It's a pooled analysis, shows in favor of ICG when it comes to reducing the risk of anastomotic leak. Clearly, there is more for us to understand in this, and there are ongoing trials, but certainly this is another type of technology which helps us in the optimal creation of an anastomosis. Navigation and AR. So this is, again, an innovative new field, and it is reliant on image-guided surgery to help us. So, brief overview of virtual reality, augmented reality, and mixed reality. Virtual reality is when you are immersed in a computer-generated world. So you will see an avatar of yourself, a computer-generated personification. And you are within a computer-generated world. It is not the real world. It requires an all-encompassing immersive headset with sound. So big headset for you to wear. Augmented and mixed reality are where computer graphics are superimposed onto the real world. So you will see your normal real world view, and on top of that, you will see additional holograms or computer superimposed graphics into your real world. It requires something much lighter to be worn, such as a pair of glasses, such as a HoloLens, for example, and this gives you an augmented reality of the world. And here's an example of the kind of things that we can do. This is in neurosurgery. We use a similar technology in GI, and it's at the moment the surgeon would be wearing a Microsoft HoloLens headset viewer, which you can see here. And they can use this in reference in surgery. So they can switch it on and off when they want to go from the real world view to now an augmented view and understand the anatomy. And we're going to see greater use of this type of technology in soft tissue surgery as we move forward. Here are the kind of examples that we can do. So this is something that my students made on their for an iPhone, using the iPhone as a viewer. And this is the very simple vascular anatomy of a particular patient from a CT scan. And on this, we're looking through the iPhone, and it's a superimposed graphic on top of our real world view. We've always had image guidance. This is nothing new. We see orthopedic surgeons using X-ray imaging on a daily basis. Ultrasound imaging in surgery, for those that have been doing liver surgery, for example, or breast surgery, we see ultrasound imaging within the OR. CT and MR have really been have only been really in the remit of neurosurgeons when it comes to intraoperative imaging. But this is the kind of theaters that we want to see, the kind of OR we want to see in the future, where we have dynamic MRI and CT, so that we can really understand the two-dimensional cross-sectional anatomy that we see in the MDT, for example, and relate that to our intraoperative view. And it's on the basis of this that we have led to augmented reality surgery. It can help us in a variety of ways. It can help us by planning it can help us by staging, it can help us in reducing complications. It can help us counsel our patients so they better understand the procedures that they're having. Essentially, it acts as a roadmap or a sat-nav for us as the surgeons. So we can see a view that we often don't get to see outside the MDT. Because this is a fantastic image. This is a T2 weighted image of a rectal cancer that tells me so much about the prognostication of this patient. They have a T3 cancer that is breaching the mesorectum, infiltrating the circumferential resection margin. They need neoadjuvant chemoradiotherapy on the basis of this scan. But that looks nothing like this, because this is a picture of me doing a robotic anterior resection of the same part of the body. And this intraoperative view looks nothing like that view on the left. And that view on the left is telling me that there is threat within millimeters. So here, I need to know where that threat is. And it is by the use of image guidance in the future and augmented reality that we will be able to then decide, actually, I'm getting a bit close to these particular nerves, for example. I'm getting close to the ureter. I'm getting close to the vessels. So this is what we want to see in all our ORs over the next decade. How do we use, at the moment, augmented reality? Well, fluorescence overlay is a use of augmented reality. This is a near infrared picture. But once we go into the overlay image, that is the use of augmented reality. That is an augmented reality image. We can use it in node identification. This is me and a head and neck surgeon doing a lymph node in the neck, and this is an augmented reality image. So it's telling me that that is the node, that is what we need to excise, and that is what it looks like when you take it out. This is a use of virtual reality. So here, it is a construction from a patient CT scan on the right. It is a reconstruction of the gross anatomy of a patient that we're going to operate on so that we can understand the vasculature. So these are the current uses that we're seeing. This is a more innovative use. So this is the first case in a human. This is a case that I did with my French colleagues in our OR in London. This is an overlay image just looking at size and have we got the size of this correct. The brown is the colon and within that is a tumor. So this is just looking at if we could overlay on this patient, what it would look like. We're beginning to see platforms, even the Da Vinci robot, having this type of augmented reality built in, where you can look for vascular anatomy. So if you're doing a liver resection, for example, you can see whereabouts the important vasculature is within the liver. And it is this use of intraoperative image guidance that will again allow us to reduce error and be more precise in our surgery. One of the difficulties is that once you start operating on an organ, it deforms. So we need to be able to have imaging and reconstructions that move with that. Because if you look at the vasculature on the top right of the screen, that is fixed. But as I move the liver around here, you can see that the liver itself is deformable and pliable. So we need the vasculature to move with it. And we're simply not at that level of understanding yet to do that. This is an example using HoloLens, so it gives you an idea of what we can see. So this is my view from the HoloLens viewer, and you can superimpose this onto the patient. And what this shows is the mesorectum, the urethra, the prostate, and the bony pelvis. And it allows me to understand where some of these planes will be. And we're getting more and more precise now to within a few millimeters of having these kind of models projected onto the patient during surgery. What the pandemic has shown us is that face-to-face teaching and face-to-face tuition and face-to-face peer learning has become difficult. So we're going to see more of telementoring. So for example, if you're using a new product and the Merrill team are unable to be with you, they can then access your OR with through the use of telementoring services. And this is an example from our team in the AIS channel. So here, here is my colleague Antonio Lacey in the OR. And then you can see how he is teaching his student who is in an office. And they can both hear each other, see the same screen, but also interact by drawing on the screen. So it provides an opportunity now for us to use 5G, high-speed internet, to telementor each other, both on a peer-to-peer level, but also on a training level as well. And then the last bit we think about is performance analytics, AI. This is something that we've never really leveraged in surgery. Artificial intelligence is this big umbrella term, but we're really interested in surgery with machine learning in particular. And within machine learning, computer vision, where we extract information from pictures. So this headline came out many years ago now from Stanford. And what it says is this neural network can diagnose pneumonia better than your doctor. What it's really saying is that the neural network or the computer program is able to predict and pick out patterns faster and more efficiently than a physician. And that's not really unsurprising, given it's processing data so much quicker than the human brain. We've applied this in colonoscopy, and here's a extract from one of our papers in the Lancet showing how we can use this type of technology to detect polyps. So as we withdraw the colonoscope, the computer algorithm is able to pick up abnormalities in the mucosa and alert the user to perhaps you now need to think about doing a biopsy or doing a polypectomy. And we're beginning to see this now trickle out into industry, and there are a few commercially available devices at the moment which you can use. And it sort of looks like this. So you can see, as we're withdrawing the scope, the blue box intimates that there is something worrying here. Have another look. See if this really is an adenoma. Is it worth resecting and analyzing, or do you simply discard it? And this is the kind of technology that we're using in our labs and researching in our labs at UCL. We can use this going into the OR and use this into surgical platforms where we extract information in real time from the laparoscopic or the robotic video feed. And then we look at those patterns to try and predict error. So if there is a combination of things that are happening within the video feed, it may signify that there is impending error. So for example, we can break up an operation or a procedure into a number of steps. This is, for example, the gallbladder dissection, cholecystectomy. So you could have step 1, callotriangle dissection, step 2, clipping of the cystic duct, then resection of the gallbladder. And the algorithm will learn each individual step, where one starts, when the next one finishes, and where the next one starts. And through that, in real time, we'll be able to pick up something like this. So as you're doing the procedure, it will tell you on the left of the screen, you are currently dissecting Callow's triangle. So this is recognition of steps. So it's phase recognition. By looking at all of this analysis, we can predict success. So this is a World Cup winning coach from England that won the Rugby World Cup. What does he have in common with us in the OR? Well, he manages a high-performing team. We manage high-performing teams. His results are all to do with outcomes and performance. Our results are to do with outcomes and performance. But why do we not do things like this routinely in surgery? Why do we not review and reflect on our performance in great detail, looking at swathes of data to try and improve? On a week-to-week basis, the majority of surgeons in the world will do a case on one particular day, and come back the following week and do the same case again. In the interim, they wouldn't have analyzed any data, done no training, and have done nothing to improve their performance. Yet we think that's an acceptable part of being a consultant surgeon. Now, I'm sure many of you are more diligent than that, and you do review your performance, review your videos, try and think about how you can get better. But the fact is, the sad fact is the vast majority of surgeons don't. And we now have tools that we're able to look at our own performance and the metrics in great detail to try and understand where we are good, where we need a bit more training, where we need to improve, how we can compare to our peers, where the errors come in. And that is how we can use data and predictive analysis to look at our own performance. So why do we do all of this? Are we going to make a significant difference by doing all of these things? Is there going to be one magic bullet? Well, the answer is that there is no magic bullet. So if there is no magic bullet, then perhaps if we improve our performance by 1% here, 1% there, it all adds up to 10% or 15%. And that's about planning, preparing, using optimal equipment, being precise, analyzing our data. All of these together will improve our performance by 1 or 2% each, and that will add up to an aggregated gain of 10, 15, 20%. And that is the theory of marginal gains. We need to think about how to continually improve our performance, even if it is just by 1 or 2% in different aspects, and it will all add up in the end. Thank you very much, and thank you for listening.
Thank you, Dr. Manish. It was a wonderful presentation. It was an amazing insight in the field of surgery and the use of technology in the field of surgery. Use of less than 2 staplers was very well taken, and I appreciate this statement. Again, the statement was more than no surgeon works less, 100% was very perfect. So I have few questions for you. Number one, you said most of the colorectal surgeries are open surgeries in UK. Why and what is the reason?
No, sorry, I meant globally. So
okay,
in the UK, we have probably about a 70% laparoscopic, 70%. But I think globally, and we must now, the world in the last 2 years has become a very small place. And it is not now about us to be thinking just of our own departments, our own regions, our own countries. I think we need to think how we can improve global surgery. And part of that is that we need to have access for minimally invasive surgery that is cost effective for everybody in the world. And yes, we have our own problems in the UK. We have many fewer robots in the UK than there is in India. If you take pre-2020, there were only a handful, and there would be often more robots in one city in India than there would be in the entire country in UK. So it is something that we need to look at with industry and work how we can get equitable access to robotics, because we need, we need the world and globally this situation to improve, not just in places like London or Cleveland or wherever else. Okay.
And the second question is, do you use ICG in all your cases?
So that's interesting. So I've been using ICG for about 7 or 8 years now, and we only really use ICG routinely in the left-sided cases. So a lot of my operating these days is robotic, and the Firefly is already on the Da Vinci. But if we're doing laparoscopic cases, then we will use ICG laparoscopically. We also use ICG for nodal detection. So we try and look for how we can do our cancer resections more precisely. And we're researching actively into the use of that. So I think it's an exciting technology. I think we're only seeing the beginning of near-infrared surgery. ICG is a very basic fluorophore, and there's so many more things that we can do with this technology when we get dyes that are targeting for cancer, for inflammation, where it can go and home in on individual anatomical structures.
True. We are using this ICG in abdominal wall reconstruction as well. To see
excellent.
Yeah.
To see the perfusion and to see the
flap. Yes.
the flap.
Yes.
Fantastic.
So it was a great talk, and I think everybody must excited with your talk. And now there is no question in chat box, so we request the second speaker, Dr. Marco Admo. He is consultant upper GI bariatric and minimally is invasive surgery. He is from University College London Hospital, the London Clinic.
Thank you very much.
Welcome, sir.
Thank you everyone for the amazing opportunity to be here in with such distinguished colleagues. I mean, I really enjoyed Professor Chan talk. Takes us to the future, what medicine brings us. The only comment I thought that when he showed the winning team coach, that was about rugby and wasn't about cricket or football. That's interesting. So I'm mostly a bariatric surgeon, and I have a specific interest in technology and how to optimize outcomes with available technology and with the future technology. I like to innovate and to try what's new. And I'm really grateful to Meryl because our paths have recently crossed, and I tried the new endocutter and I was mostly impressed. So I will share my screen and see if I can share my screen now. Hope you can see. Okay. Can you see my screen?
Not now, sir.
Oh, that's slightly. Let's try again. Second time lucky.
Yes.
Perfect. So, I mean, stapling is always a topic dear to my heart, and as a bariatric surgeon, I'm sure you will confirm, we find hundreds, if not thousands, of cartridges every year. So sometimes, we just do the job without putting any thought into it. So I like to reflect a bit more on what we're doing and how we can improve our outcomes. And of course, everybody knows that the primary objective of stapling is to create anastomosis, creating airtight and watertight staple lines with preventing leaks and hemostasis. And we all witness failure of staple lines, either mechanical failures or tissue failures, or occasionally ischemic failures. So I will talk more about the stapling, and then I will go back to the human factors, which I think it's what matters the most. It's what the interaction between the user and the device. We can have the best machine, but if you're not comfortable in using it or you're not an expert, then you will encounter problems. So this is an old IFUs of the old staplers, but that's the old Eticon and Covidian size chart for the staplers. The black ones in available then. But now we know that the stapling device are recommended for a maximum staple height of 2.4 millimeters closed when compressed. So I'll mostly be talking about the stapling of the stomach because that what matters the most in bariatrics and what we use all the time. And you can see we have now a range and a variety of rainbow colors for our cartridges. with various type of thickness. So if we want to chart that, we have a continuum from gray to black that takes up to a thickness of roughly 2.4 millimeter when the staple is closed. And if you want to look at the stable continuum, we will have a range where the stapler works well. And then, of course, if the tissue is too thick or too thin for that stapler, then we encounter problems. I think every bariatric surgeons can tell the story of unformed staple lines in thick continuums when the black cartridges were not available. So now we have a fairly good range. The question is when and why. So I tend not to believe what industry tells me. I'm trying to find myself the answer sometimes. And then if we measure the stomach thickness, and this is a study done on cadavers, the thickness was between 3.1 and 1.6 in excised stomachs. But what matters to us is measuring in vivo, because that's where we're stapling on live stomachs. And ultrasound, we can measure ultrasound showing a thickness between 2.8 and 4.2. And another study with CT scans showing a thickness between 2 and 5. So we are well above what is recommended for stapling with the normal staplers. And interestingly for us, there was no difference with the patient's body mass index. So the old belief that the bigger the patient, the thicker the stomach is not always true. So if we look at the studies, available evidence, our stapler shouldn't be working because the maximum staple line is 2.4, but the stomach can be up to 5 millimeter, so twice as much. And also, some of us might decide to add in some procedures, in some cases, a staple line buttressing, which adds further thickness to the staple line, 0.5 to 1 millimeter. So potentially, we can have a 6 millimeter stable stomach wall to staple with a stapling device that goes up to 2.4. So I figured out that probably tissue compression must be the key for allowing us to produce safe staple lines. And so this is defined as tissue compression. It's very obvious concept, and the idea is the compression exerted by the stapler. It will allow all the fluids to come out and the thickness to be reduced. Is that relevant for a bariatric surgeon? Is that relevant in terms of choice of stapling device? I think it is, or at least you need to be aware if your stapling device or the stapling device you're using in that specific case provides a homogeneous compression or a sequential compression, what's the compression time? Because the force you apply with the stapler is applied, or compression has to be applied over time. And it's important to realize that the longer you apply for, the thinner the tissue become. And ideally, you want to compress before you fire the device. And when you fire the device will compress the tissue as well. All the recent developments in stapling technology have been all around this concept of pre-compression, compression along the compression fall. I remember a few years ago, having a discussion with some eminent bariatric surgeons about compression times. And I remember someone saying, oh, I will keep my stapler locked for 1 minute, 2 minutes before firing in a sleeve gastrectomy. Now, there are 2 points in compression stapler. Is the minimum compression time, the ideal compression time, and the maximum compression time. Once you pass the maximum compression time, the force exerted by the stapler will cause tissue ischemia, and of course we will have a leak. So no one has ever been able to identify what's the maximum compression time. The consensus should be around 5 minutes. So the moment you lock the stapler, you can't really go for a cup of tea come back and then fire the gun. On the other hand, when you lock the stapler, ideally you would like to wait 15, 30 seconds or 1 minute, depending on the tissue thickness you have under your gun. So I did try in the past to answer some of my questions and measuring the gastric wall thickness prior to the stapling. And I figured out I could do that during the surgery using ultrasound, and I will do it in a gastric sleeve. Gastric sleeve, why gastric sleeve? One is probably the most popular procedure we do worldwide in bariatrics. Two, gastric sleeve is probably the procedure where we test the staplers to their limit. Lots of new manufacturers are producing stapling devices specifically tailored to gastric sleeves, because that's where we see the failures. Most of the failures are staple lines. So these are the patients I used back then, just the standard patients you would see, which you use for sleeve gastrectomies, with a variety of range of body mass index. And to limit the variability, I only use female patients. And that's the technique I've used. I use a standard, intraoperative 7.5 megahertz probe, the one you normally use for liver ultrasound, intraoperative liver ultrasound. And I took a measurement immediate to the stapler before stapling, and identifying anterior and posterior wall and the bougie. And I took the measurement twice, as you normally would do, and then I did the measurements for all the cases. And I did the measurement for all 4 out of 5 firings, excluding the 5th, because sometimes we don't reach the 5th firing easily. We stop 4, enough to complete the sleeve. Sometimes there's less space at the top to play with ultrasonic probe. And that was, I did look like back then. And these are fairly old pictures. I mean, I did these measurements a few years ago. And you can tell the probe catching the medial edge of the stapler and trying to grasp the thickness of tissue just before the tissue enters the stapler. And that's what I found back then. And you can see a diagram on the left of the screen and a real image on the right. And if you are ultrasound trained, or you can read ultrasound image, you can see the shadows, the 2 walls, the bougie, the lumen, and the stapler. And what I found was pretty much what I was expecting. So both walls are the same thickness. And as you can notice, I did use SIM guide in the sleeves. So the total thickness I measured was 2.7 millimeters in the antrum for 5, 1, and 2. It was 2.5, 4, and 5. So yeah, it was I was above. It was recommended by the staplers. Interestingly, I found there was a difference between the antrum and the body and the stomach, which in a way would justify choosing different colors by going north. So, which I normally do in normal practice. I would start for sleeve, I would start with a black and move to green and gold, or we'll start with the green and perhaps move to gold, trying to find the right compromise between staple line integrity and hemostasis. So yeah, I assume that tissue compression was the key, and I can confirm by my own experience that tissue compression is the key in stapling, and that will allow us to create a efficient staple line. So go back to the human factors. So what's the interaction between the user and the device? I think that's the key. We spend a long time in training, teaching our juniors how to use a stapling device correctly, how to choose a stapling device based on the procedure you have in front of you, based on the patient you have in front of you, and the type of stomach. The choice of cartridge is essential. Now we have a range of colors. Then compression time before stapling. Again, it's not standardized. I remember a few years ago, they introduced the concept of 15 seconds. I would say there is a range between 15 seconds and 1 minute, but sometimes you might elect not to do any compression if you don't deem that needed. Again, depends on which part of the stomach we are stapling. Stapling techniques are also important if you do cross staple lines. And finally, it's a big topic in bariatric. Do you trust your staple line to be naked, simple, or you prefer reinforcing it? And if you do so, if you do use a staple line reinforcement materials or sutures or clips, there's a variety of alternatives, most of which apply only to one procedure, which is the silica gastrectomy, where we do test the stapling that max to the limit. So the human factor, I like to show what it's like using the staplers, and that's the video we took yesterday. And this is not a silica gastrectomy, just but this will be a formation of a gastric pouch in a gastric bypass, and I wanted to focus specifically not on the screen or what's happening inside, but what's happening outside, how to use a stapler. And I chose this part of the procedure because in the formation of gastric pouch, I normally use my left hand for the transverse part of the pouch and my right hand for the vertical side. And as you can see, the aim is to be able to use your stapling device as a grasper's first, as an instrument first, and then to perform the stapling in a comfortable way. So, and that was, of course, real time. I don't like edited videos. That was a real time of the stapler from the left hand side, and this will be from the other side. Sorry, that's the let me just get out of this, and then I'll get the other slide where I use it from the right hand side, and then I will do exactly the same stapling with the right hand. I think it's important to show the handling of the devices. It's something, if you try something new, and this is not entirely new for me, this new device, but definitely not, I don't have the experience of that with other devices, but it's perfectly comfortable to be used and fairly intuitive. And you can also use one-hand use, and that's the final product of the gastric pouch. So to finish off with the stapling, I'll show a little bit of a video if it doesn't bounce too much of the silica gastrectomy, which
yes, sir, please.
Is testing the capability of the device. Techniques, our surgical techniques have developed along the technology we had, harmonic coagulation, diathermy, bipolar, and then staplers. And I can happily say that my technique has developed around the staplers, and I tend to use the different staplers from different mega staplers for different operations. And that's that was the first time. That's the video was the first time I was using the Mary stapler for a silica gastrectomy. So I'm replicating the technique I developed, a different stapler using a new stapler, and it worked perfectly fine. And as you can see, choice of cartridge. This patient is a woman, so I kind of estimated the thickness of the antrum by using a double action grasper to pinch the gastric wall. And then I thought a green cartridge with SimGuard was enough, and then the staple line was formed correctly. I tend to staple always with the cartridge below, so I can see the closure of the staplers, the staple formation, which was perfectly fine, and there was a nicely hemostatic. I think combination of 3 rows of staplers and SimGuard makes it fairly hemostatic. And then again, the video is not edited intentionally, but if I progress with the second firing, again, I would use for the second firing is still green because.
So we can't see your video, sir.
Can't you?
No, it's fixed. Yeah.
Oh, apologies. I've been talking.
It's fixed to human factors. Yeah.
I've been talking just purely about the video I'm seeing, but not the. Sorry about that. Let me see if I can make a new share.
Yeah, now it's coming. Yes, yes.
Now you can see. So apologies for the technical glitch. So yeah, that's what I was describing earlier on. So that's using a green cartridge on an antrum with a Maryland cutter, reinforced with SimGuard. SimGuard, I'm sure it is not extremely popular in India, but I'm quite fond of it for fossilic gastrectomy. And then the staple line was inspected. It was perfectly dry and informed, so the choice of green cartridge was correct. And moving forward, that would be the second firing, always from the left hand, and then moving forward, because I don't want to bore you with the standard procedure. That's using the stapler as a grasper in a two-hands technique to mobilize the fundus and move the fundus away from the stapling, so we can actually remove all the ghrelin producing cells from the gastrectomy, leaving what I would regard as a tight sleeve without the fundus. And then you can see the bougie being moved freely. And there was a 34 French bougie. You can see the staple line is very hemostatic and is very reliable. And in this case, I chose to use a single color for the whole sleeve. I used green all the way up. Normally, I would downgrade the two firings to gold to maximize hemostasis, but in this case, it wasn't really needed. And then that's the stapling number 4, which will allow me to complete the entire sleeve. And as you all know, the last firing can be a bit crucial, and again, it takes a particular effort to remove the fundus and to make sure the fundus will go into the remnant. And I have to say, I found the gun extremely handy and extremely intuitive to be used. And I always roll the gun at 90 degrees to have access to the posterior wall, and I maximize the tension of the staple line on the posterior wall. And I land the stapler at the basis of the left cross to make sure there is no remnant in the sleeve. And that's the final product, which is would regard as a very good staple line, fairly straight, hemostatic, and total success as far as I'm concerned for a new stapling device. I was using that day. That was the first time I was trying it, and then it was straightforward. And then I did the leak test as I normally do, using the stapling device as a clamp. So I use the stapler I like to use my stapler as a grasper, as a stapler, and as a clamp. So I like to have instruments that are versatile. And then a leak test is purely to make sure there's been no mechanical misfire. And I use a diluted methylene blue around 60 to 100 ml under cricoid pressure. This leaves dilates well. I put some additional Liga clips because this is mostly for surgical superstition. I don't think they're needed. And then that was the end of the procedure. And then patient went well. I was discharged the same day, so the morning after. So now I will stop the sharing of the screen. So that's showing the entire sleeve. So I thought I wanted to talk to you about how to optimize outcomes, in bariatric surgery, a little bit of science behind the stapling, and sharing with you my experience with with a new stapling device, and we can bring to the techniques. Technology can bring to techniques to surgical work. Before I complete, a couple of comments on the fantastic presentation of Professor Chand. I limited my talk to the stapling technology, but of course, we could go on for talking about energy devices or ICG. I currently do use ICG in bariatric for selected cases. I think it's important to have technology available, learn from our colleagues who are using it every single day for every single case, and then use it on selected cases. So I would use, for example, ICG mostly on revision cases or patients where there is poor perfusion for variety of reasons. So I kept it slightly shorter. That's a prerogative of bariatric surgeons. We tend to get the job done in a little time. So I'm more than happy to take any questions and have a bit of a more open format from now on. Thank you.
Thank you, sir. It was a great and enlightening talk, and we appreciate the way you measure the thickness of the bowel by yourself. It's simply great. There are a few questions for you. Do you use SIM-guard in all the cases?
I do use SIM-guard in all the sleeves, but no, I won't use it in normal wrong-way gastric bypasses or one anastomosis gastric bypasses. So occasionally, I would use it in high-risk patients if I do a one anastomosis gastric bypass. The reason for that is if there is a risk of bleeding. For example, very hypertensive patients are medically very high risk. I might use a SIM-guard, the reinforcement for the one anastomosis gastric bypasses, but definitely don't use it for one gastric bypasses unless it's a particular revision where the stomach tissue seems very fragile and very sclerotic, so it's not very elastic. In that case, I tend to use reinforcement. But the only procedure where we use it routinely is the gastric sleeve.
And do you believe in overswing the staple line, at least in the upper third? No.
Sorry? In the
do
suturing?
you believe in overswing the staple line?
I do believe in the staple line. I do believe in the staple line.
Reinforcement of staple line by suturing?
Yes. The point is that the suturing, there are different techniques, and then if in order to do an efficient suturing, sometimes you have to allow yourself a little bit of space. So sometimes I tend to be very tight to the bougie, to an extent that if I would suture, I am at risk of creating stenosis. So that would be my concern. But I found SIM-guard or the reinforcement more standard than suture. So every time I suture, I want to make it look nice. So I tend to be slightly more crafted rather than standard. So it's slightly more difficult to teach, but it's a very good alternative to staple reinforcement suturing because it does reinforce the staple line.
One question for Dr. Manish. Hello, Dr. Manish.
Yes.
So Dr. Chintan wants to know, every technology or advancement is a cost to the patient. What is your views on cost versus benefit ratio ex robotic surgery?
Is it a cost to the patient? I don't know. If you've got improved outcomes, less chance of getting complication, less chance of needing to go to intensive care, less chance of having a hernia in the future, less chance of having bowel obstruction in the future. I think all of these things must be considerations as well. So the way that I look at these individual increments, if you say that adding ICG or adding a new staple gun or whatever it might be increases the cost by a few $100s, the actual hospital episode often is in the thousands. So these are only very small percentages. It might increase the direct OR cost of that particular instrument. So if an instrument costs $100 and the new version or an upgraded version costs $120, you'll say that it was a 20% increase, but it's not a 20% increase because that whole hospital episode for that patient may have cost $10,000. So then actually the only increase that you've seen is $20 divided by 10,000, which is a fraction of a percent. So I think that this is a very typical sort of, middle grade manager way of looking at things in the hospital when we hear that there is a subtle increase by $20 in the price of a gun. The actual hospital episode is what we should look at. And that hospital episode is often many thousands of dollars. So I think, and if you are going to save 1 or 2 leaks in your unit, or if you are going to save 1 or 2 incisional hernias, all of these things add up. So I think we have to just be a little bit smarter in our understanding. Not everything is an increased cost. Often there are decreased costs. If you do things better, you'd have less complications, you have less use of intensive care, you have less need to reoperate, and you have less need to have further operations in the future.
Yes, true. Means, suppose you have 1% chance of incisional hernia in one patient, but for that individual patient, it is 100%.
Absolutely, yeah, absolutely.
Yeah,
I agree. If we can add to your comment, Manish, in bariatrics, worldwide complication rates are nowadays extremely low, way lower than colorectal, way lower than upper GI cancer surgery. And it's probably because of the nature of the specialty, not because bariatric surgeons are better than colorectal, because most of the surgeons can do both types of surgery in the rest of the world. And so every time we introduce anything new, which tends to be more expensive, it's very difficult to justify it because the margins are extremely low. So if you have a 1% leak rate, then you get it down to 0.5. You have to get it down to 0.5 or even more, actually. If you have a 0.3% leak rate, which is usually the standard rate we quote for gastric bypass, in order to demonstrate you are improving that, then you need to do a significant number of cases. And it is a very, very demanding, introducing new technology.
Yes, and I think that's where we all want to be. I think it's easier to reduce a complication rate from 10% down to 2%, but trying to get a complication rate from 2% down to 1% is much harder, of course. So your original question about justifying the use of expense, then yes, there's I don't see, if you take surgery such as appendectomy, which has a relatively low complication rate, it is done in most hospitals globally as a laparoscopic operation. I don't see the need in using robotics to do a simple case such as that.
Sure.
And to demonstrate an advantage for an appendectomy and perhaps even an inguinal hernia is very difficult to do with increased expenses. So there is an argument for both. There are some other factors that we need to consider as well, which is, of course, longevity of the surgeon, ergonomics, etc. But again, they are more so for either the high volume surgeons or the ones which are doing procedures that last a long time. Again, a 15-minute laparoscopic operation is probably not going to be too taxing on our joints compared to doing a 3 or 4 hour case. So I think there are lots of factors to consider, but I think the simple argument always of just looking at it as looking at the OR costs, I think we should look at things more holistically as how much is this increase in the bigger picture rather than just the direct OR costs.
And one more question for Dr. Manish. The question is, some circular staplers have adjustable staple heights, while some has fixed closed staple heights. What do you use, and what is your choice of using that staples?
Yeah, I think the in cancer surgery, it's different from doing bariatrics, for example, where often you're looking at different thicknesses of tissue in different patients, and you might decide, and again, I'm no expert here, and I'll defer to Marco, but certainly you might feel as though you want to use a particular colored stapler for one part of the anastomosis, and then you might change to another for individual patient reasons. For me, I only do cancer surgery, so I don't do inflammatory bowel disease surgery. So in that, I use what would be a blue staple cartridge for all of my patients, because there is very little variation in that anatomy. I'm not doing inflamed tissue. I'm not doing particularly, different tissue every time. So I use the same every time. And I suppose in that respect, it's a little bit different from what Marco was saying. It is easier to standardize my practice in elective surgery than perhaps it is in bariatrics, where you have to tailor for the patient a little more. So in my practice, I will use the same stapler, the same type every single time, because that's the routine. We use the same, and it should be almost boring. Everyone in the OR should know exactly what we're doing, exactly what the steps are, and it doesn't change. But I imagine that's different for you, Marco, in your practice.
Depends on the procedure. I think that the biggest challenge in terms of stapling is when we talk about sleeves and the thickness of the antrum, or we talk about revision surgery. Primary surgery, there is the procedures are fairly standard when we go away from the sleeve. For example, I use the circular stapler for wide gastric bypasses. And when they are primary bypasses, I tend to use the blue as the one used in colorectal surgery. And then I will not require a variation in staple height. But this is a circular stapler. It's not a linear stapler. It will have very long staple line. And the thickness of the upper stomach is fairly thin. So in fact, if you use a triple stapling technology, you can use what is called a TAN, which is a combination between white and green. So I think I don't see a need, at least for standard bypasses, where it's a circular stapler, to have a variation in caliber.
Same question. Next question is on that only. Many companies have come with gold reed loads as an option between blue and green, with the difference of just 0.2 mm. So he wants to know, is there any difference, or what's your preference? Gold.
Well, I remember when the first time the gold came out, and I thought, oh, let's try using it. I think there is a role. When I measured the gastric thickness, the difference was actually 0.2 millimeters. I found between antrum and then fundus. So that would be for me would be the rationale to move by 0.2 in a standard sleeve, for example. So when I move from green to gold, but I do reinforce a staple line which had thickness. If I'm doing a gastric bypass revision, I tend to use, for example, green. But there are some times where when you have a feel with the grasper of the stomach, and if it is not as thick as you would expected, but because it's revision, you might feel more comfortable using a gold rather than the standard blue. So I think there is a role for the gold. Definitely, there is a role for the gold, as well as for the black.
Yeah, Dr. Jaideep, you want to ask a question? Can you come chip in and ask your question regarding expectation from Merrill? Dr. Jaideep.
Thank you very much. I'm not doctor. I just work with Merrill. My question was to both Manish and Marco. Both of them are extremely eminent surgeons, as we know, and both of them actually have been very actively involved in education in UK. My question would be, what would they expect from a company like Merrill, who has a kind of passion or who has a great degree of interest in education? Where do you see Merrill playing a role in the coming years in UK? And if you see any gap anywhere left by the present companies where you think Merrill can fit in?
Manish?
Marco, I'll let you start then.
Okay. It's I think it's been a bit of fresh air for us, because innovation in stapling has been traditionally very slow, and we've been in a way at two brands market with pros and cons of each one of the staplers. And with years and practice, we ended up knowing both brands, both makes very well. And then from a technological perspective, what I can see in Merrill, it's something like a best of both worlds in a way. It looks like someone has put in a room 100 surgeons to say, okay, write down what's the best of points of this make, what's the best points of this other make, and I put on the engineers in the other room and say, okay, make a stapler, let's go both points, both plus points. So it is something different, and having the capabilities of which are different from other two makes, potentially can change our techniques, can improve our techniques. So that's why I see that from a purely technical perspective, and can definitely stapler as delivered. You've seen the videos today, and that was real videos. It hadn't worked. I would have said it didn't work. So there is a novel approach. There is a novel approach which is not in contrast with the existing technology, but it's embracing the technology, embracing different technologies, trying to get the best available, and reinterpret that in a new light. So I think that there's a good amount of work there. It's a good starting point. I think we have a very good starting point, and then it's now like what's next. So that would be my interpretation of the relation with Merrill. We're coming out. I know there's in UK it's relatively new. I know in the other part of the world it's fairly established, but it's something new, something different, not being too different, which I think is the key. Surgeons are animals of habit, and they like to use always things they're comfortable with. So we are not creating a revolution in terms of handling, in terms of buttons, in terms of user experience, but we are combining existing experience from different makes, creating a unique experience in a way, which I think is a very good way forward. So that's my take. What do you think, Jay?
Thank you very much, Marco. Really appreciate your point of view. Manish, would you like to add something?
Yes, I think the changing paradigm in how industry and clinicians are working together is very much through education and through educational support. I think that's very different from perhaps years ago, where it was more to do with the sales side of things. And I think Merrill has a very strong reputation and pedigree with its education and research, with the fantastic facility that you have. And I think that's really the gap in the market, where other companies may have concentrated a little bit too much on sales of product. I think Merrill's commitment to education and to helping their surgeons understand some of the issues with their practice and how things can be done different, I think that is probably where the gap lies. And I'm looking forward to working with the team and Marco and others to help in that endeavor, particularly in the UK and Europe and elsewhere, wherever that need may be. So that for me is the importance, that it's not just about selling product, it's about selling the vision of this is what we want as a company, this is what our strategy is, and I think that's where Merrill is particularly strong.
Thank you very much, Manish. Over to Dr. Rajesh, please.
So thank you. I think there is no more question. It was a mind-blowing session filled with education and knowledge. So thank you both the speakers, Manish and Marco. I hand over the session to Shraddha for vote of thanks.
Thank you.
Shraddha? Shraddha, are you there? Jaideep, you want to finish the session?
Yeah, definitely. I'm sure Shraddha is there, but probably must have got caught up in something else. Thank you very much, Dr. Rajesh. I really appreciate you moderating the whole program. A real heartfelt gratitude from us in Merrill UK. And would also like to thank Martha and Manish. It's not easy to have two very eminent surgeons like them spending this amount of time with this topic today. I think we end the day being highly enriched with the thoughts. The presentations from both Manish and Marco were absolutely fantastic. It's been an eye opener. Trust me. I mean, I'm in the industry for so many years, 30 years, but not very often I have seen this kind of insightful presentations. So once again, thank you to Manish and Marco for a great job. Really appreciate, and I think we look forward to a great association between Merrill and UK. Over to Dr. Rajesh. Thank you from my side.
So, concluding comments from Dr. Manish.
Well, thank you very much for this wonderful educational morning. It has been delightful to be able to share some of my experience and also listen to Professor Adamo and also Dr. Rajesh about other practices as well. I hope that we can see you all again in the next webinar in the series, where we can hopefully go into a little bit more detail about some of the technical aspects of surgery. So thank you again to the entire team, and look forward to seeing you next time. Dr. Marco, your concluding remarks.
Thank you. I echo Manish's comments that they have been very refreshing and extremely interesting webinar. I enjoyed really listening to all of you, and I hope we can repeat the experience soon with more technical, with more topic and more technical topics. Absolutely, I agree with
thank you very much,
Manish, and thanks to Mary
for
so providing us the opportunity.
Thank you.
Thank you so much, Dr. Rajesh, for moderating this session for us. I'm sorry, I just had some technical error. I couldn't unmute myself. It was really a pleasure to have you, Dr. Rajesh, for moderating this session. I think it was a wonderfully conducted session, and at the same time, the moderation was fantastic. Thanks a lot, sir, for being there. Thank you, Dr. Marco, and thank you, Dr. Manish, for having a wonderful presentation.
Thank you.